We also train ear professionals around the UK and internationally in endoscopic earwax removal, and we have an online web portal where if you are in the UK and you've got a blocked ear, you can visit our website, enter your postcode or local town and city, and find your nearest earwax removal specialist. So got two really interesting cases. These are the procedures I really enjoy doing. It's when we're removing dead skin, keratin or earwax off the eardrum. Whenever you approach the eardrum, you just really need a steady hand, and it really gets the adrenaline pumping. So these are my favourite types of procedures. So here we have a young girl, actually. She's in her late teens. She's been using a cotton bud, and she's actually pushed some dead keratin right on her eardrum, and it's impacted against her ear canal wall. So what I'm doing at the moment, I'm using a fine end gauge, trying to lift, elevate and retract this dead skin off the bony part of the ear canal. We can't touch the bony part of the ear canal. If we do, it's going to be very painful for the patient. So I'm just hovering over, just ensuring I don't touch the ear canal. But the keratin buildup is quite firm, it's quite adhered, it's quite a thick layer there at the base of the ear canal. So I've just gone back in with the fine end. As I was entering the ear, two cilia, the two hairs from the ear canal entrance, got trapped to the vacuum, and it's taken it into the ear, but that'll come out in a moment when I come back out with the suction probe. So we're just on the anterior wall here, again just peeling this wax, but it is really stubborn wax. It's quite a thick glutinous layer of dead keratin, sorry. So at this point, I think I'm now going to go back in with a full zollner suction probe because it's just not powerful enough, that fine end. And just on the posterior canal wall, I'm just lifting this away from the bony part of the ear canal. You can just see the eardrum revealing itself there at the back on the right hand side. But again, the vacuum's just not powerful enough. It's not taking this off completely the eardrum. So yeah, you need really steady hands. The patients are awake, they're not asleep, so no patient's going to keep their head completely and utterly still, so you're having to also mitigate for any sudden head movements from the patient. So here's when I've gone in with the big zollner suction probe because the fine end just wasn't powerful enough. Even the standard zollner suction probe, it's not. But I wanted just to get the skin off the canal wall, so I've got an opening where I can use some forceps to grip onto it. Couldn't do that before, there was no opening, but there's just enough access there now to the back, to the right hand side, to the rear, the posterior part, where I can grip on hopefully with some crocodile forceps and extract this. So we're just going to go in with the forceps. We just have to be, again, really careful because the tip of the forceps is quite sharp. If we come in contact, you could puncture it and perforate the eardrum. So got some keratin there, but still some remaining. Okay, just need to be so careful we don't make contact with the eardrum or the canal wall. So this is where it became a bit interesting. So you can see there this cylindrical shape right in the middle of the eardrum, and it's so round, it's unreal. So I asked the patient whether they had grommets before, because sometimes when you've had a grommet, when it heals, it's a thinning of the membrane, because your eardrum is 1 millimeter thick, there's 3 membranes. When it perforates and when it reheals, it's the middle layer only that reheals, so it's a thinning. So I just wanted to be careful, because if that was a heel perforation and I go on there with a fine end, I could quite easily perforate that. So I performed a pressure test. If it was a heel perforation, the eardrum would be very flaccid, it would be vibrating quite a lot, but it wasn't. So I was pretty sure that wasn't a heel perforation, it was just a more keratin. Went back in with a fine end, just removed that. So in a moment you're going to have a pre and post image. I think it's kind of good actually at the end of the procedure that I do this, so you can remember what it looked like and what it now looks like. So that's a before and after shot. So that's the first patient. The second one is a lot more complicated. It's a similar concept, however, with removing stuff directly off the eardrum, but here it wasn't keratin, it was a syrupy honey type of wax. This is the worst type of wax, it really is, and it's just all over the eardrum. I was like, oh God, how did you manage that? So the patient had been using hydrogen peroxide drops, and they hadn't been draining the ear, so they've been keeping the drops in the ear all night. So this wax, which is probably already quite a sticky consistency to begin with, had become more sticky and mushy because of the hydrogen peroxide drops. They tilted their head all night, and this is just drizzled over the eardrum. And removing this type of wax is difficult enough on the outer third of the ear canal, the cartilage portion, because it's just so sticky. Removing of the eardrum, it's a lot more complex than the first procedure. So I'm just approaching the eardrum. I'm using the full Zollner suction probe here because it's so thick and glue-like. I needed that extra power, and you can see we're peeling a bit off there. Just to give anyone a head start with this procedure, I didn't perform the procedure to remove every little speck of wax off the canal wall. We just wanted to make the patient hear again. By doing that, we would have cut, grazed, caused injury to the ear canal. So if you're one of those with a bit of, who wants to see everything spotless, you can just switch off now, because this is not that procedure. I think this procedure will appeal more to the specialists who perform the procedure themselves, ENT, audiology. I think they'll kind of appreciate the complexity of this procedure. But if you're just one of those armchair experts thinking they know it all, just turn away now. I'm sorry, I'm just going to be quite blunt, because I've just had quite a few, again, negative comments. I'm just a bit, people say ignore it, and I do ignore it, but it's just ridiculous that some people sit on the armchair and think they know better than a world-renowned specialist who's a UK pioneer in the procedure. I'm not bragging, just stating the facts. If you don't like that, turn away, watch another channel. So, again, just using a fine end. Again, it's just right on the eardrum. And this is what gets the adrenaline pumping when we're doing procedures like this. When it's so. And by the way, I should mention, this patient was turned away from another specialist locally. They said, look, it's too complicated. We can't remove it off the eardrum. Go away, put drops in, etc., etc., and come back. They just wanted it removed. So again, just on the pars flaccida, this is the top part of the eardrum. It's a very, very thin part of the eardrum. We're going to be really careful here because it can easily perforate when we approach that part. So at this stage, I can see the majority of the eardrum, and I asked the patient whether their symptoms, whether they could hear, because sometimes less is more. If they could hear at this stage, I would have left it, but they still felt a bit blocked, and I performed tympanometry, which is a pressure test. And basically what we do, we change the pressure in the ear canal, and we present a sound, a low frequency sound, and we've also got a sound level meter attached to, it's like a microphone basically. And what we're doing, if the eardrum is very tense and it's not vibrating, the sound that we amplify in the ear will hit the eardrum and bounce back out, and we can record that. So the less sound that's bouncing back out the ear, the better, because that means more sound is entering the eardrum, which is what it should be doing. So we present a sound in the ear, and we record how much sound is coming back. And if there's a lot of sound coming back, then we know the sound is not being absorbed, it's not conducting through the eardrum. And that's what I found at this stage. So when she said she's still struggling with the hearing, I thought, oh no, it's complex enough as it is, and I'm going to have to go back in and try and get a bit more out. And because it's such a thick type of wax, a honey syrupy wax, I've just got to use the full Zollner suction probe, and you can see we're just at the base of the eardrum now, inferior quadrant. Just want to remove that thick glutinous now, so hoping once I remove that, the symptoms would have been alleviated. You can see how much, very little room we've got to work with. That Zollner suction probe is almost the same diameter as the inner part of her ear canal. So I would say we can see about 2/3 of the eardrum. So I've just had to go back in with the fine end because there just wasn't enough space with the full Zollner suction probe. So again, we're just targeting this inferior quadrant. It's weird, as I'm narrating this, I'm turning my head to the side to get a better view myself of what I was doing. So again, just going to avoid the eardrum. We want to avoid the canal wall. So I'm just going to the anterior part of the eardrum now. So she's got a bit of an anterior recess, a bit later on in the procedure. I had to bend the fine end to get access. So I can probably say we see about 90% of the eardrum. There's still a tad bit left anteriorly in the anterior recess. So that's the part that's very difficult to obtain that access into. So I think here, this is when I bent the fine end a bit, just to I can get it in the anterior recess to avoid the bony part of the ear canal. There we are. So just literally on the eardrum here. And you can see we're just peeling this dead sticky wax keratin off the eardrum. There we are. As I said, we are making direct contact with the eardrum. So you just have to really, really steady hand, and we always got to be aware that the patient doesn't move suddenly. So I'm really pleased with that, and the patient's symptoms, I did the pressure test again, the eardrum is moving perfectly. So at this stage, we're confident her symptoms have been alleviated. So I just wanted to mop up a bit more just at the base to see if I could anyway. So ideally, what you're hoping for, you suction some of this wax, dead keratin, and it just peels all off in a long strip, but it just wasn't in her case. Brilliant. And I'll show you a before and after image a bit later, like I did the thing. You'll see the difference. So that's the top part, that's the part of the cedar. We're going to be very careful. That's the thinnest part of the eardrum, and it can be easily perforated. You can see just how sticky this wax residue is. You can see it on the zone, on the fine end gorge. It's coated with this soft, gooey wax. And I'm just trying to mop up as much as I can on the posterior canal wall now. When we go a bit deeper, a bit more medial, you'll see a bit of a bulge, and you'll see there's a layer of this wet, sticky, honey-type, syrupy wax keratin on there. Again, I don't know whether, is this just a bulge of dead skin, or is there a bony part of the ear canal underneath? So I just had to tread very carefully, because if there was a piece of bone protruding and this layer of dead syrupy wax is coating it, and I make contact with that bony part, it'd be very uncomfortable. So it's at on the cartilage portion. So here we can put a bit more pressure in. You can just see how difficult this type of wax is to remove. It just doesn't vacuum, it's sticky. I'm just hovering over the canal wall, just making smooth brushstroke movements. And the patient was overwhelmed. She's really been struggling with her hearing on this side. I was getting her a bit depressed, and she was quite literally a new person when she left, because obviously she could hear, she got her confidence back when she came in. She was very quiet, very mute, partly because she couldn't hear, she couldn't even hear the suction machine. She just, when we cleared that wax off her eardrum, she said, "What's that noise?" I said, "Well, that's the suction machine." The suction machine is quite noisy. It's probably about 65, 70 decibels, so it's quite astonishing actually. It's quite like almost like a hairdryer, that kind of volume. She just wasn't able to hear it. But I'm really pleased with that. So, I mean, all this sticky, gooey wax now will dry up. I've told her to stay away from the hydrogen peroxide drops. So it will dry up and naturally migrate. But we can see the eardrum, we can see the tinge, the blue tinge, that's all visible. Just trying to see if I can get a bit more of this sticky, gooey stuff out. Brilliant. And there's the eardrum in its full glory. So you can see the hammer bone. So I've got a before and after shot coming up. That's before. And then you'll see the after shot. So you can see the difference. Thank you for that, guys. I hope you enjoyed that. If you're watching on YouTube, please do subscribe, select the bell icon so you'll get notified as and when I upload new videos. And if you're watching on Facebook, please do like, follow the page, make a comment on the video, like the video, and stay tuned for some more videos. Thank you. Bye.